In this video, we'll quickly go through the diagnosis, treatment, and prophylaxis. We'll also have a bit of a detailed explanation on the NACO strategy for testing, and at the end of it, we'll give a quick shot on how to revise this whole topic in just few minutes. We also put up a video on HIV basics, so that I would recommend all of you to just please go and have a look at that video. I'll put up an iCard as well as a link. I'll provide a link in the description as well. So before we start, just a quick recap. So basically we have these HIV genes, which are basically the GAG gene, POL gene, and ENV genes, which are very important. Each of these genes gives rise to a protein, which is an integral part of a particular genome and the virus, which makes this virus infective and successful. The next thing you have to realize or understand is the basic concept between sensitivity and specificity. In simple words, sensitive is a test where the test is able to detect all positive cases. So there is a possibility that there can be some few false positives also. Whereas the specificity is to rule out all the negative cases. So there might be a chance where a small amount of false negatives might be possible. So that is why we always use a combination of a test which has a high sensitivity and specificity, so that we can rely on this particular investigation. As far as lab diagnosis of HIV is concerned, you can classify them into three parts. One is a screening test, which is your ELISA or rapid or simple test. Confirmatory test, you can have this P24 antigen detection, viral culture, or HIV RNA testing. This HIV RNA testing, you can have RT-PCR, you can do a branched DNA assay, nucleic acid sequence based amplification, viral load by RT-PCR, and in cases of pediatric HIV, the HIV pro-DNA, that is more useful estimation, so that it can give you a clear picture. Along with this, you will have a supplemental test like Western blot assay and line immunoassays. Now remember, whatever you do in HIV, the three things are very important. One is it has to be done with a proper informed consent, and the confidentiality is very, very important. You cannot declare or you cannot tell results to somebody who is not related to the patient, and that too has to be done with the proper permission of the patient, and the report has to be issued only with proper counseling. This is a pre-test counseling and a post-test counseling as well. We'll talk about screening assays. So it can range anywhere between 30 minutes for a rapid test to 3 hours for an ELISA. It is highly sensitive and specific. So whatever test we do, we'll try to reconfirm it with other more specific tests. Antigen, what we use for testing is mostly this P24, GP120, GP160, and GP41. All these things we have heard in the first lecture also. And HIV2 is GP36. You can detect HIV 1 and 2 separately, or there are kits which are combined together so that it is for you to detect HIV testings. So again, just a quick recap. You have these genes which we select. This is your GP120, GP41, and P24. P24 is very important because last time we told you that the reappearance of P24 antigen is a ominous sign. So next is ELISA. We all know that it's very easy to perform and you can do a large number of samples. And for HIV diagnosis particularly, there is a third generation and fourth generation ELISAs which we use. Third generation basically uses recombinant or peptides against the HIV antibodies. And the fourth generation ELISA is also capable of detecting P24 antigen that uses monoclonal antibodies. So this can be used, the fourth generation ELISA can be used for diagnosis of patients even in the window period. A quick review on what are the different types of rapid immunoassays. You have the dot plot assays, like what you going to use for you have a membrane on which the enzyme conjugate and substrate are there, and the colored areas will be the positive test. Then you have the lateral flow assays, particle recognition test, and dipstick or Coombs test. All these things are being used for the purpose of HIV diagnosis as well. You have the supplemental tests which are specific, and whenever you get a positive test with a screening test, you can use the supplemental test to identify or to decide your final diagnosis. The most important among them is a Western blot test. So they detect antibodies towards all the gene products like GAG gene, POL gene, envelope gene, all those things. So as per WHO, it has to be at least 2 envelope bands with or without GAG and POL bands. Whereas the CDC says presence of any two, that's P24, GP120, GP160 or GP41 bands. Confirmatory test, we use P24 antigen because this is antigen is inside the core of the HIV virus, and it is detectable after 12 to 26 days of infection and can be there for up to a month, and generally use a 4th generation ELISA. The purpose of this is to confirm the diagnosis of HIV or to look for HIV in the window period, late stage of HIV or AIDS. The diagnosis of HIV in infants might not be very much reliable. More reliable is the pro-DNA estimation and the monitoring of progress of viral infection, and to resolve whenever there is a equivocal results in your Western blot testing. The confirmatory test, you can also do a viral RNA detection, and generally after 2 weeks it is very much useful. You can use, as I told you earlier, reverse transcriptase, branch DNA assay, NASBA or real-time PCR for estimating the viral load, and it is very good for diagnosing HIV in the window period, for viral load monitoring, typing the type of HIV virus as well as to detect the antiviral drug resistance genes. The proviral DNA, which is useful in pediatric HIV, it can also differentiate latent HIV infection from active replication, and it's useful in the window period as it gives you a very good real-time estimation of the amount of virus in the blood. Now, the isolation of virus from the blood and tissues is generally very expensive and it is not very sensitive, so it is not used for a routine diagnosis. The method what we use is a co-cultivation method. So what is this? So basically it is a virus is grown along with virus infected and the virus non-infected susceptible cells. So basically the virus is present inside the patient cells. During the mixture of virus infected and non-infected cells, these viruses come out, they infect the healthy cells, the active replication takes place, and this replication can be seen in the culture supernatant solution. What all cells we use? The patient's lymphocytes and monocytes which are infected, and the healthy donors, which are basically means seronegative, highly susceptible and metabolically active cells can be used. So what is done? Sample is collected from the patient, the cells are separated out, donor cells are separated out the same way, and they are mixed in a suitable culture medium and incubated for days to weeks, and the virus will slowly come out and infect the donor cells. So what are advantages? Basically, they are highly sensitive, useful in a very low viral load infections, and it will detect the replication of the component viruses. Other tests which can be used is CD4 cell count, which use the flow cytometry method. CD4 cell count is a very good estimation to look for risk of opportunistic infections, for initiating an antiretroviral therapy, monitoring the response to therapy. So what happens here? You have the activated T helper cells which produce interleukin-2 and interferon gamma. This will stimulate the polymorphonuclear lymphocytes. They also produce some abnormal proteins like neopterin, beta-2 microglobulin and soluble IL-2 receptors. In India, you have this NACO for the purpose of diagnosis, treatment, counseling, everything. All the guidelines are given by NACO and it is mandatory to follow these guidelines. So what is the basic idea? First screening should be done by a highly sensitive test, whereas second and third should be done by a test which has a high specificity. The same type of test, so same type of kit should not be used again, and you can use a supplementary test when one of these tests is giving an equivocal or intermediate results. So let's see the algorithms one by one. The first one, you have the algorithm 1, which is used in transfusion. That is, whenever blood is collected in the blood bank, use a kit. If it is positive, you immediately are going to discard it and basically destroy it. And if it is considered negative, then you can take it up for the next series of testings and before you give it to the patient. Then you have the algorithm 2A, which is basically for surveillance in the community, where you use 2 kits. The first kit, if it comes negative, well and good. If the first test, which is very sensitive, comes positive, you do a second test with a highly specific testing method. So if both are positive, yes, you proceed with the post-test counseling and counsel the patient and do the next steps for the treatment of the patient. If it is the highly negative, that is the second test, which is highly specific, is negative, then you report it as negative testing. Then you have the algorithm 2B, which is for diagnosis of HIV or AIDS in in symptomatic patients. So here you can use 2 or 3 kits. The first kit, as we said, it is a highly sensitive test, so it is positive. Then you go for a highly specific test, which can be positive or negative. If it is positive, that is both the first test and second test comes positive, you go with the post-test counseling. If the second test, which is very specific, comes negative, then you go for a third test, which again a very specific test. If the second specific test is also negative, then you'll report it as negative. If one test among the three, that is the second or third, comes positive, you will tell it indeterminate and you are going to follow up the patient, repeat the test after 14 days and then proceed accordingly. Finally, you have the algorithm 3, which is basically for asymptomatic patients, for antenatal screening or for patients who are undergoing surgery. So again, here you use 3 tests. So first one is a very specific test, very sensitive test. So there, if it comes positive, you go for the next step, where your second and third, you are going to use a very specific test. So if all the 3 tests comes positive, then you don't have any doubts, you are going to go on with the post-test counseling and chart out your next steps. If the 2 specific tests comes negative, then you have to think of whether the patient is under a high risk category or low risk category. With a low risk category, you can say the patient is safely negative. If the patient has a high risk behavior or comes under high risk category, then it's supposed to be considered as a indeterminate result, where you can use your other supplemental test and confirmatory test for diagnosis. So again, the same way, you have this these one specific test comes positive and one comes negative, that is again considered as an indeterminate result. So how do you monitor or how do you look at the prognosis of the patient? Generally, you look for the CD4 cell counts, HIV RNA load, P24 antigen detection, looking for abnormal proteins. What happens to the viral antibody levels? Obviously, there's an immune collapse. So the antibodies are not very much consistent with the later stage of disease. So this cannot be used as a very reliable marker for the diagnosis or prognosis of infection. Pediatric infections you look for is mostly the best method, what is recommended as HIV DNA detection. The ELISA for IgG can be done after 18 months of age, because there's a clash between the maternal and the baby's immunoglobulin. So it's better to do after 18 months of age. Window period, you can do HIV related antibodies around 2 months time. Third generation ELISA kits can detect by around 22 days, and P24 can be detected using 4th generation ELISA kits by around a month's time. HIV RNA can also be done around 10 to 14 days of infection. So next step is to start the antiretroviral therapy. So what are the clinical goals? You have to basically prolong the patient's life, improve the quality of life, look at the virological load and look at the reduction of the virological load, and basically boost the immunity or keep it at one particular stable level, reduce transmission of HIV, and the ART can be started at any stage of the disease, irrespective of the CD4 cell counts or the presence of opportunistic infections. So what we use here is a highly active antiretroviral therapy or HAART regimen. Basically uses a multiple combination of drugs so that there's a lesser chance of developing antiviral resistance. So these are the group of drugs what we are using. You have the nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, and nucleotide reverse transcriptase inhibitors. So NACO recommendation is basically what is called as a TLD regimen, as a fixed dose combination of tenofovir, lamivudine, and dolutegravir as first choice regimen, and given as a once daily tablet. And you can monitor the CD4 cell counts and the viral load for around 3 to 6 months to monitor response to the treatment. The main problem with HIV is the opportunistic infections. So opportunistic infections should be treated before you start ART. The most common ones, you give a cotrimoxazole therapy for once daily for the cases where the CD4 cell counts have dropped to 350 cells per cubic millimeter, or the clinical stages 3 and 4. So WHO clinical staging has been mentioned in the previous video. Please, if you want to, you can go back to the video, have a look at those clinical staging and come back. The secondary prophylaxis is given to patients with pneumonia after treatment and continued till CD4 cell counts remained at more than 350 cells per cubic millimeter for 6 months. The next thing you want to treat about is the opportunistic infections, the cryptococcal meningitis, where there is a secondary prophylaxis with fluconazole and it can be started with HIV patients with cryptococcal meningitis who have completed treatment and the CD4 cell counts remains more than 200 cells per cubic millimeter for 6 months. This cannot be used as a primary prophylaxis. Third most important thing, most important opportunistic infections, tuberculosis. So you can start with INI-CET to prevent latent TB infections and can also prevent reinfection after exposure to a open case of tuberculosis in the family. The problems with ART is obviously the toxicity, cost of the regimen, risk of developing drug resistance, and limited therapeutic options. One thing what we have to remember is about the inflammation reconstitution, immune reconstitution inflammatory syndrome or IRIS, which basically what happens is the viral load decreases. So once the viral load decreases, the immune system starts to build up and there is exaggerated immune response. So previously acquired opportunistic infections show a lot of inflammatory response, makes symptoms of the infection pretty much worse. One thing what we need to know is about the post-exposure prophylaxis. So any kind of post-exposure prophylaxis, what all has to be done. So first is a first aid. You can report to the nodal officer, take a first dose of PEP, test the baseline for blood-borne viruses, decide on further course of the post-exposure prophylaxis. Everything has to be documented and all these steps have to be done with the proper informed counseling and a written informed consent. The follow-up testing schedule is there, you have to follow up and the precaution should be advised to the patient during the follow-up period. So what happens as soon as there is any kind of needle stick injury or exposure? For splash injuries, you can irrigate the area for minimum of 5 minutes. Don't keep the finger in the mouth or squeeze the blood. Try to use antiseptics or detergents. Earlier we used to say do not remove contact lenses, but now the recommendation is that you give a proper irrigation and single pinch technique, you can remove the contact lenses. The first dose of PEP has to be given within 2 hours ideally, and the maximum time allowed is around 72 hours. Beyond 70 hours, there is no effect of this PEP at all. NACO recommendation is basically based on the amount of exposure and the status of the source patient. So what is this exposure code? So mild EC1 is a very mild exposure where there is a mucous membrane or non-intact skin exposure with very small volumes for a very short duration. So next you go to EC2, which is a moderate exposure where there is a mucous membrane or non-intact skin exposure with large volumes for several minutes, or there is a superficial exposure with a solid needle of superficial scratch. The severe exposure amounts to large volume transfer by a hollow or a wide bore needle or a deep puncture, or there is a visible blood on the device or the needle which was used in the patient's artery or vein. Source code will start with the opposite right, HIV negative. So the patient from whom the needle stick injury or the splash event occurred is negative as per the NACO strategy. The HIV status is negative. So next you have the source unknown, which is basically HIV status of the source patient is not known or blood is not available for testing. The SC1 is basically where the patient is HIV positive. It's either asymptomatic or a very low viral load of less than 400 copies per ml of blood. And the source code 2 is basically HIV positive. The patient is symptomatic with a very high viral load. Now, what is the post-exposure prophylaxis given? You have a tenofovir 300 milligrams, lamivudine 300 milligrams, and dolutegravir 50 milligrams as a fixed dose combination for 4 weeks. This is the basic chart of the whole process of PEP. So, if whatever the exposure code is, if the source patient is negative, then you don't need to give post-exposure prophylaxis. And if the exposure was very, very less, it did not enter the non-intact skin, or the patient is HIV positive with a very low load, then also you can decide about not giving post-exposure prophylaxis. For anything else, a very simple way of remembering is you will give post-exposure prophylaxis with either the fixed dose combination of 5 tablets, that is tenofovir and lamivudine, which is given once daily, and lopinavir, ritonavir, which 50 milligrams is given twice daily. The alternate is basically the tenofovir, lamivudine, and efavirenz 600 milligrams OD, which is given for a post-exposure prophylaxis. with which group of patients you can decide not to give post-exposure prophylaxis, basically whom they are already HIV positive, exposure on intact skin if the patient is HIV negative, exposure with low risk specimens, and PEP beyond 72 hours, you can decide not to give post-exposure prophylaxis. Side effects, initially they can be nausea, diarrhea, muscular pain, headache, and fatigue. Later on, the person can develop anemia, leukopenia, thrombocytopenia, and unless until there is jaundice and liver tenderness, please do not stop post-exposure prophylaxis. And more than 95% of compliance is required for a very good prevention of the infection. Finally, we come to the NACO guidelines to prevent neonatal HIV. So, pregnant women who are HIV reactive are initiated for a lifelong ART. The newborn babies are initiated 6 months with syrup nevirapine immediately after birth for about 12 weeks if the duration of ART's mother is less than 24 weeks. Baby can also be given cotrimoxazole prophylaxis at 6 weeks till 18 months. So, to sum up, finally, you have the diagnosis where you have 3 types. You have the screening test, supplementary test, and confirmatory test. The NACO guidelines basically talk about the screening type 1 is for donor samples where you use one test. The algorithm 2A talks about HIV surveillance where you use 2 tests. The algorithm 2B contains about symptomatic patients. It can be either 2 or 3 tests depending on the result. And 3 is basically for diagnosis of asymptomatic patients where you use 3 tests. The first of whom is a very sensitive test. The second and third is basically highly specific tests. When you want to monitor infection, look for the CD4 cell counts, HIV RNA load, P24 antigen, and presence of abnormal proteins like neopterin and beta-2 macroglobulin. Pediatric HIV, look for pro-viral DNA, HIV RNA estimation, P24 antigen, and ELISA can be done. That is for the immunoglobulin G after 18 months of age. What we use for treatment is HAART, basically tenofovir, lamivudine, and dolutegravir. And opportunistic infections, prophylaxis with cotrimoxazole for pneumonia, fluconazole for cryptococcus, and INI-CET for tuberculosis. Post-exposure prophylaxis, you have the regimen, which can be either 2 types, that is TL and LR regimen, which is basically fixed dose combination of 5 tablets, tenofovir, lamivudine plus lopinavir and tenofovir. Alternatively, tenofovir, lamivudine, and efavirenz can be used. So I hope I have summed up the whole thing as a short video and I covered most important points required for undergraduate teaching. Please do go back and look at the video which has been given in the first part to understand the basics of HIV infection and staging of the clinical staging of WHO disease. I am sure that will sum up the HIV topic for undergraduates. Please do like and subscribe to my channel. Share this video as much as possible. Thanks for watching. Thank you.